Hi, I'm Sarah Mitchell-Chen,
And I'm Dr. Jory Fleischer.
and we want to welcome you to Rush Recaps. This is a series of educational videos made to address some of the most frequently asked questions we hear from patients, families, and care partners here in the clinic. This project is brought to you by a generous grant from the Parkinson's Foundation to help implement primary palliative care into the clinic appointments. So today with that, we are going to ask you, Dr. Fleischer, if you could help explain the difference between palliative care and hospice care.
I would love to. So first, I would like to start this conversation by saying thank you for even clicking on this video if it has a title that says palliative care or hospice, because we know that these terms carry a ton of stigma and a ton of taboo. And if there is myth and misconception and mystery and misunderstanding around anything in healthcare, I think a lot of it is around this. So I'm going to let you in on a secret, which is palliative care is really the comprehensive, holistic, kind of whole person approach to treating symptoms, managing symptoms, and improving quality of life in people living with a chronic or serious illness. So, whether or not your healthcare provider has identified as someone who is providing palliative care, until we have a cure for Parkinson's, for Lewy body dementia, for the conditions that we treat, until we have a cure, we are focused on symptoms. We are focused on improving your quality of life and your function, which means we are providing palliative care, whether we acknowledge it as that or not. So it gets a little bit confusing because there are physicians who are fellowship trained in palliative care. So what does that mean? There's kind of two levels of palliative care. There is the person who is caring for you for your primary condition. So say as a movement disorders specialist, I care for people with Parkinson's and Lewy body dementia and related disorders. I am not a fellowship trained palliative care doc, but I can take care of a good number of things that fit into quality of life and managing symptoms and helping people to understand what's coming next and plan for their future so we know what matters most to them and we can create a roadmap to help them achieve those goals. On the flip side, there are palliative care specialists who've done additional training in palliative care and hospice, and they may specialize and be in the hospital. They may focus on people more closely towards the end of life, or they may have an outpatient practice where they see people with all kinds of conditions who are facing different chronic, serious conditions and take everything from I'm having issues with my breathing, or I'm having pain that's difficult to manage, to I really need to get my family on the same page and help understand my condition and what I want and help everyone sort of rally the troops so we're all on the same page and can move forward together. So that is palliative care. And palliative care can be delivered in the hospital. Palliative care can be delivered in the clinic setting. And sometimes there is home palliative care. So there are agencies out there who can send a nurse on a pretty infrequent basis to kind of check in the context of movement disorders. Home palliative care may not offer a ton because a lot of times those nurses, those specialists have a lot of training in things like cancer and things like heart failure or end stage kidney disease. They may be less familiar with Parkinson's and related disorders, and you may get a lot more help in terms of symptom management and quality of life from your movement disorder specialist. But we want you to know that they're out there. And that kind of bridges us to the related topic of hospice. We all take a breath. So hospice is an entitlement. Hospice is part of your Medicare benefits. The same way that if you signed up for Medicare, we don't really feel any guilt about saying, yeah, okay, like I got my medications through Medicare, right? Hospice is part of that. Hospice is an extension of care, and hospice is a team-based approach to improving quality of life in someone with a life-limiting illness. So usually this means that a healthcare provider, the treating healthcare provider, has said, based on the best of their knowledge, the person in front of them with at least 50% certainty, we think that person may have 6 months left to live or less. If the treating provider feels that to be true, then you may qualify for hospice services, which means that an extra team, an extra layer of support can come to you, not caregivers. So check out our caregivers video. Hospice doesn't provide 24-hour caregiving, but a hospice team is typically a hospice nurse, a hospice social worker, and they may have various other members of the team, sometimes chaplains, sometimes various different therapists. Hospice will come to the home in most cases, evaluate the person living with the diagnosis, evaluate the family, their care partners, and figure out how they can be most helpful. Hospice takes over prescribing most medications. They can provide supplies like pads for the bed, like adult protective garments if needed. They can help with things like a hospital bed and other sort of durable medical equipment. And really importantly, when something changes at 3 a.m. or the caregiver just has a concern or a question and they don't know where to go, any hospice agency has to have a 24/7 phone number that you can call and someone will pick up and help address your concerns. Doesn't mean that they'll send someone out immediately in the middle of the night if it's not an emergency, but they will help navigate you through the question or the situation at hand. So hospice provides an extra layer of support, and it can be in addition to still seeing your movement disorders neurologist or some of the other team members. The primary care physician may step out of the picture when hospice steps in. That's one of the trade-offs. Other big questions, Sarah, that we should address about hospice?
One of the ones that we often get is, where is hospice provided?
That's a great question. So the vast majority of people, hospice is there to help you age in place and stay in your home for as long as that is safely possible. So most hospice is home hospice. However, there is inpatient hospice, which means if someone is receiving home hospice, for example, and they have a symptom that the hospice team is simply unable to control in the home, and this is not usually the case in patients with movement disorders. We don't tend to see this very much at all. But if that were the case, if there was agitation or if there was pain or some other concern, any hospice agency is affiliated with an inpatient hospice unit where that individual could be transferred and cared for in sort of a hospital-like setting, or even in a hospital in hospice-specific beds. Sometimes people may have a medical emergency. They may have had a catastrophic injury or stroke that the team says, this is not going to be survivable. This person may not make it out of the hospital. They could transition to the inpatient hospice unit from the hospital as well. So there are different ways to get there, but that is really a minority of hospice care.
And then one other question that might be helpful to address is, when would it be time to have a conversation about hospice? Or when would it be time to think about starting hospice?
It's a great question. And unfortunately, so what the research tells us is hospice is there for you. If you're on Medicare, if you have insurance, hospice, you're entitled to this. And there are lots of benefits. We actually know from really great studies in cancer and now in Parkinson's disease that people who receive palliative care and hospice do better. They have better quality of life. Their caregivers do better. This is not giving up. This is adding on. This is wrapping around, okay? Despite that, very few people with Parkinson's and related disorders actually use those hospice benefits. It's like having a pile of gift cards and accidentally never using them, right? That's yours to use and it's a benefit to you. So in the United States, the average amount of time that a person spends in hospice is a few days. And the reason for that is because often the healthcare providers are too worried to bring it up or don't bring it up until it's too late. And it's not fair to you, to your family, or even to the hospice team to try to sort of come in and bring in all of this support at the very last minute in chaos. The point is to wrap you in this support and be there to improve the quality of life in whatever time that is left. And the smoother transition that is, the better. So if any other outside healthcare provider has mentioned hospice to you, you can always bring that up to your Parkinson's or related disorders, your movement disorders neurologist. We will always, be happy to talk with you through that. If that is something that's come up to you, if a family member has brought that up, if it's just, how will I know? That is always a great conversation to, let your neurologist know that you want to talk about. And it can be a long conversation. So if you bring it up at the very end of the conversation, at the end of the appointment, there might not be enough time left, but that might be, you know what, let's have a separate appointment just to really focus on this. So please bring it up. We know that a lot of times that worry and that concern is sitting with our patients, with our care partners, with our families, and isn't brought up until too late. It's never too early to discuss this, right? All that your neurologist can say is, I don't think that you're a hospice candidate right now. You're doing really well. Let's talk about what I'm seeing and what I see that makes me say you're doing really well. What is it that you are seeing that makes you concerned that hospice might be coming soon? And be able to bridge that gap.
That's very, very helpful. And we hope that these videos continue to be a helpful resource to you as well. If you have specific questions, like Dr. Fleischer said, write them down, bring them to your next appointment with your provider, and you can continue these conversations. We really want to help arm you with more information and resources to get you the best care and help answer some of those questions that you may have. So continue to check out the growing number of RUSH recap videos and the additional resources on the patient education page. And with that, we want to thank you so much for being willing to tune into this video and the continued videos that we're putting out. So thank you so much.
And share with others, share with your family.
Yes.
Thanks.